So I am Ashutosh Kothari. I am an oncoplastic and reconstructive breast surgeon practicing at the Guy's and St. Thomas's hospitals in London. I have a very strong interest in academia and research, and to that end, I'm attached to the Department of Life Sciences and Medicine, King's College, London, where I participate in original research on breast cancer and also with medical devices. I organize and teach on several reconstruction courses around the world. Globally, I'm attached to the Sir H.N. Reliance Hospital in Mumbai, India. I have a special interest in partial and whole breast reconstruction, especially whole breast reconstruction in women that to date unfortunately have to undergo a mastectomy following a diagnosis of breast cancer. I was introduced to meshes as early as 2011-2012 and have routinely used them in my reconstructive procedures, and over the years have been involved in the development and design of a few of these meshes. I was introduced to TiLOOP by my colleagues and friends in Florence, Italy in 2019. So I use TiLOOP quite routinely in my post-mastectomy direct-to-implant immediate breast reconstructions. I also prefer using it when I'm doing revision surgeries for women who've had suboptimal results following whole breast reconstruction. Recent meta-analysis have confirmed that there is less morbidity, seroma formation, and better long-term results with TiLOOP when compared to other meshes. The material is soft and pliable and easy to work with and has a very small learning curve, if at all. In fact, I'm so impressed with the material that towards the end of last year, when we did a couple of robotic mastectomies, we used the TiLOOP bra pocket as part of the breast reconstruction, and surprisingly, it withstood the rigors of being pushed through a small 4 centimeter incision and maintained excellent shape and form. We also know that it is much more cost effective compared to other meshes. In fact, it's much more cost effective than similar biologics, making it easier for healthcare systems to adapt and offer it to a wide variety of patients. So TiLOOP is unique in that they've managed to use titanium, which is a relatively inert material, to cover a polypropylene mesh. Now we know that titanium makes the surface hydrophilic, and in doing so, it reduces inflammation and increases cell vitality. So these characteristics then make it integrate faster into the breast tissue. And we want this in breast reconstruction, where we want tissue regeneration and ingrowth rather than inflammation and scarring, because it leads to capsular contracture. So TiLOOP, the structure, facilitates tissue regeneration and integration, and even ensures strength over a longer period of time. So due to the fear of breast implant-associated anaplastic large cell lymphoma, the breast cancer community has moved towards using nanotextured and microtextured implants. Now we know that these implants have little or no traction on the smooth pectoral fascia and are prone to rotation and malposition. Now the TiLOOP mesh, which is very, very easy to use, ensures that these implants stay where I intend to put them. This is particularly important when you look at anatomical implants, because most of the women today prefer a more natural look and prefer the teardrop implants, and these implants are then held in place by the TiLOOP mesh. Over a longer period of time, the mesh guarantees that there is no bottoming out, there is no lateralization, there is less seroma formation, less capsular contracture, and there is no malposition over time. Both the TiLOOP bra and the bra pocket are easy to use. They're very thin, they're pliable, but at the same time they're durable and retain their strength. We've had no problems with visibility or palpability of the mesh. Now, the bra can be used in a couple of ways. You could either take a purse string around the bra and put it around the implant and then suture the implant onto the pectoral fascia in the way that you want to. Alternatively, you can use it purely for anterior cover. The bra pocket, on the other hand, is very, very easy to use. You can either create the pocket outside the body and then place it inside depending on the incision, or you can suture the pocket with a couple of stitches superiorly, invert it, put the implant in, and then put the implant back, especially when you use inframammary crease incisions. And you can also have a lot of ptosis or medialization, or no ptosis if that's what you want. So it guarantees good results, less seroma, less capsular contracture, and lasting results over a longer period of time.